And welcome back to the brand new episode of the Health Tech Hub, where each and every month we sit down with a guest speaker and we talk about everything healthcare and health tech. I'm your host, as always. I'm Paul Buckland. I'm the growth strategist here at MiiCare, and this month we're joined with our very own Vice President of Business Development, George Kowalski, to take a look back at his 25 plus years in healthcare and kind of look at healthcare's biggest challenges from somebody that's got 25 plus years in healthcare. So I really hope you enjoy the episode, and let's get right in. Thanks so much, George, for joining us on the podcast.
Thank you very much, Paul. It's great to be here again.
So, George, we work at the same company. You're all over our LinkedIn. People have probably seen your face before. They know you travel all over the country, kind of waving the MiiCare flag. But could you just give a little bit of background on yourself, kind of your history, and then what you do at MiiCare, just to kind of give people that maybe don't know about you an idea of who you are and what you do?
Yeah, of course. Thanks, Paul. And it's actually really nice to hear people that I've met at exhibitions and conferences recently saying that I'm all over LinkedIn and they're seeing me everywhere and obviously advising on age tech and so on, which is lovely to hear because it's great that, some thoughts can get out there to do some good. So that's nice. Yes, I'm the Vice President of Business Development for MiiCare. I've had a long sort of relationship with the NHS because my first role when I left university was to become a directorate manager in a hospital trust, and then did part-time nursing at the same time on day release to Macclesfield School of Nursing. So that sort of put me in the right place to deal with specific issues in health. And then from there, I have worked with the NHS ever since, for organisations like Siemens Healthcare Services, Scribe, for example, and EMIS, where I've been looking at and assisting with product development for EPRs, electronic health records, theatre systems, and so on. So yeah, it's been a very, very entertaining and actually full career that I've had with the NHS so far over the last 25 to 30 years.
Doesn't make you feel old at all then, George, seeing everything for the last 30 years.
It certainly does, Paul. And to be honest, it's really strange because I did an exhibition recently, a conference where I was on stage as a panelist. And one of the things I mentioned was how things seem to be in this cyclical nature where what we were doing 20 years ago seems to always come back to the way we were. And we're doing it again in the same way now, and everybody agreed with me. So we had matrons, we had sisters on the wards, and so on, and it's just going round and round in circles. So yes, we're spending lots of money, but we're getting not very far.
Not very far, which is kind of unfortunately the story that the NHS continues to write. Everybody is banging their head against walls in different ways out there for innovation, just for speeding things up. Whether it's in some of the previous podcasts, we've talked about kind of the burnout side for the actual workers in the NHS, all of the stuff they deal with as a result of just poor infrastructure, right? There's not enough people to go around, and they're kind of getting shouted at by the general public and all of that terrible stuff. But with your, 25 plus years, which is what I'll say instead of saying 30, making you sound a little bit older, with your 25 kind of plus years of experience, specifically in the healthcare, I know there's been quite a lot of shifts, right? Obviously, early 2000s, we started to shift. I had one of my podcast episodes with Barbara Hakin. She was talking about the early 2000s and the prescribing and the kind of drug side of it. There was lots of shifts. But for you, what do you think the most significant shifts are in terms of how we're approaching patient care, and also how kind of innovation in healthcare in the NHS has kind of come around, or what kind of shifts have you witnessed since you've been working?
Yeah, that's a fantastic question, Paul, because I think my career sort of spans that shift, and I can sort of let you know where it was when I started and where I am today. So in connection with healthcare within hospitals and the NHS in the past, we were a very administrative sort of enter data, capture information, get paid for it solution kind of NHS in the past, where, for example, the most important elements of healthcare for NHS trusts to exist was getting money for patients based on coding for their diagnoses, obviously, and their procedural information that they have entered into the system. So it was all about a patient administration system being this be all and end all, where all patient data would be entered. Coding would be performed based on the procedures they had performed, and money would be received based on those procedures or those codes. I think, to be honest, in those days, the big thing for us was, oh, it's going to be a spine in the UK, and all data will go into one database. There'll be one individual electronic patient record, whether that was going to be Lorenzo in the old days or whether it's going to be whatever it is now. And to be honest, that was 30 years ago. And has it worked? Has it happened? No, I think, to be quite honest, we've sort of darted here and there. We've tried to go through and improve what we've done. We've gone from Reed to SNOMED, and we've gone through and we actually looked at different systems of how that data can be captured electronically and automatically. But in all honesty, it's moved along so slowly. It really has been a laborious task because, of course, with change, you still have to perform the actions that you do every day. So, you can only move at a certain pace. And unfortunately, the NHS moves very, very slowly. One thing I will say, though, is that where we've moved is to a digital paradigm. So this digital paradox, or this paradigm in itself, which we're moving towards, will be the future. It will happen. It is happening now, and it will be the future. The way it is happening now is not right. It just isn't right. What we should be looking at is the best of breed systems. We should be looking at the government having an independent body which assesses the organizations which are worth their salt and have a great application or a great system or a solution, and then from them accredit them with the badge of approval, so everybody knows that that solution provider provides a solution which is best of breed. It is the best. And we're just not there. We're having assessments performed by independent parties, which are actually businesses who are competing against each other. So, sometimes when you are assessed by a competitive body, they don't want you to do well because they're a competitor of yours. That just isn't ever going to work. So I think, to be quite honest, what we are looking at now is this shift towards digital healthcare, rather than them saying, hey guys, let's see how many companies can be out there to offer a service. They should have said, hey guys, we need a digital solution, a digital service. We want you to make sure that the solution you provide is best of breed, and that you can not only show all your certification, your accreditation and everything else, but also that you can prove that benefits realization is something that comes out of your solution, and of course return on investment, and basically what you say it can do is what it does, and that, believe it or not, isn't always there, Paul.
Yeah, I think now as well, there's so many people fighting over kind of the same pie, and so many people are on the surface level seem to do the same or very similar things, or they're kind of put under umbrella terms like, remote patient monitoring, things like that. They're put under these umbrella terms, and they said, oh well, they do that, and they're not really being distinguished from, let's say somebody might have an element of remote patient monitoring, for example, but that's only an element, whereas some people are just a sole RPM model, and they'd be put under the same umbrella, but they'll have different applications, and as you said, with the being kind of evaluated and assessed by your competitors is never going to go well. We need somebody that is an unbiased, thinking the NHS loyalist is what is going to be the best for the NHS. Need to see the NHS as a very big baby that needs to be kind of looked after. But yeah, I think you probably hit it dead on. Dead on. I mean, I don't have 25 plus years experience. I'm only 26, but that is something that I've noticed. With my kind of 4 years or so in health tech alone, is just there's so many people kind of offering these solutions and different solutions across a whole range of things. But there's just kind of no source of truth. Lots of people build technology without coming from a healthcare background or a health tech background or something like that.
Yeah.
So they have an idea which sounds good, right?
Yes.
Like, oh, this will definitely work, but then in practice it doesn't make sense. But they wouldn't know that because they don't have the in practice kind of, like they haven't got the boots on the ground experience to say, well, no, how it should be done is this way. So the technology needs to start here and kind of get to here with
Yep.
these steps in between. And And that's a shame because it muddies the water for good solutions that are actually that have, you know, a health care kind of backing. They have somebody that's been in healthcare that's kind of leading the vision, and they just get bundled in, and that's really a problem because some really good solutions kind of go unnoticed, while solutions that maybe aren't as good are wasting time and money for trusts all around the UK. We see it all the time, right? People putting loads of money into solutions and it just not working out, and then they're kind of the company is, you know, back where they started, just with a whole lot less money and
Yeah.
you know, however many years on. But
And I
something that was
think,
interesting. Sorry,
sorry,
go on.
sorry, Paul. I think one of the things I'll add to what you just said there as well is that I think there are probably two or three big issues there. The first one is you're absolutely spot on. The word solution is what we are looking for.
Hmm.
So these 65 or so suppliers that I looked at when I was working for a previous organization, which was looking at accreditation and certification of particular products,
Yeah.
these suppliers that I was assessing, looking at, they all do something. They all
Hmm.
offer a camera, they all offer a sensor, they all
Yeah.
offer something or other, one thing or another, but they are not an entire solution. And that inevitably means that their application, their solution will not work. It just won't work.
Hmm.
Because if you're doing, for example, I use this analogy. If you're cutting the grass with a lawnmower that doesn't have a blade, then you're not going to be cutting much grass, are you?
Yeah, you're
That's the
not going
thing
to be doing
about
much.
it.
You're going to be spending a lot of time and effort with no outcome.
Correct. And that's exactly what some of our suppliers are doing here and now today. MiiCare fortunately have the entire solution. And that leads me on to point number two. And point number two is that the MiiCare solution gathers over 1 billion data points with over 70 plus biomarkers. And that's a lot of data being gathered every single second of the day. I'm sure other organizations can say, well, our product captures various information as well. The beauty of ours is the fact that the MiiCare solution captures all the data and presents it in the cloud, obviously, for production into the dashboards and the reports that we produce. So the data is being used for a reason, and the data insights can tell carers, family members, etc., there's something happening here. There's an anomaly to the actual patient's routine or the user's routine that needs looking at really quickly, because this could, if you don't, lead to a fall.
Hmm.
So first things first, yes, the entire solution needs to be available. Secondly, if you're capturing data, use that data meaningfully. Don't just capture it for the sake of capturing it and then do nothing with it. That's a waste of time. And I think the last thing I wanted to say as well is the fact that there are all these organizations who obviously are just, trying to, sell you this or sell you that. I think one of the biggest problems is the fact that when you put your solution into practice, you need to ensure that the patient then feeds back how well it's done. And this is why I lead back to the conversations that I've had with government to say, look, there are so many competing angles here where, for example, you've got tech assessors who are not only assessing technology, but then, reselling it or distributing it with their own markup. That's taking money away from the NHS and from, of course, us, the taxpayers. So there needs to be changes made. There really does. And I'm sure we'll get there in the end. Well, I'm hoping we get there in the end. But nevertheless, it's very obvious and clear to me, but maybe it's because I've spent so much time in the NHS. But I think, if someone had sat down with me and gone through what changes I would make in the NHS, I would give them clearly a focal point for them to try to get to.
Yeah, I think too many cooks in the kitchen is a common problem. I know I've mentioned it a few times, but there's too many people trying to kind of have a say in different things, and it sways focus. It just like I said, it muddies the water. It just makes it really difficult to, as you said, have a real focus. Right, this is the first thing we're going to solve. Let's find solutions that solve this.
Yes.
Okay, great. And then this. Obviously, it's easier said than done with the NHS because it's huge, right? And it's there's lots of moving cogs, but that kind of leads me into what I wanted to say about the second one, actually. Kind of the next question I wanted to ask was, obviously the landscape's evolving, has been for, especially nowadays with AI and, the last 5 years or so, there's been a real kind of innovative shift from what I've seen. Lots of people are creating new solutions, they're implementing AI. There's a real potential to remove administrative tasks and have kind of insights, and like you said, with these data points, having a whole range of data that is actionable and usable, not just being collected for the sake of saying we collect it, right? Each piece of data has its function, it's going in, which is going to help either the caregiver, clinicians, family members, whatever the case may be. But right now, as it stands, I'm going to probably shorten down how many you need to say, but what do you see the biggest gaps being in care? The one or two, maybe three, depending on how many you've got to, and kind of how do you think digital health solutions, such as us, MiiCare, right, play in addressing them?
Yeah, absolutely, Paul. I mean, yeah, even in my time with the NHS, I've seen such massive changes. To be quite honest, back when I started being a director manager in orthopedics, trauma, and general surgery, we had mental health wards in our hospital, and it was all dealt with internally. And it was terrible if we didn't treat our patients for mental health, and send them to wherever they were safe, with an outcome to helping them with their issues. These days, I hate to say this, that there is more pressure on community because we are sending our patients out into the community without the care they need. And I think, to be quite honest, the problems you've got in the past where, you were as a consultant, as a doctor, or as a nurse, you were stressed because you had to look after the patients that you were assigned to. That's now completely changed, because that's still the case in the hospitals, but now you've got patients who are wandering the community, who basically are being looked after as well as they possibly can be by carers and by community nursing and nursing staff and so on. But there just aren't enough members of staff to look after all these patients who desperately need their care. So the biggest change I think that's happened, as far as I can see at this moment in time, is that the carers, whether they're nursing staff, whether they're carers or whoever they may be, are really struggling with looking after their care load. They have so many patients, and they just cannot continue at this pace to look after the patients they are assigned to look after. So digital health, what it's supposed to do, and what it does with regards to the MiiCare solution at least, is that it's supposed to help those carers by providing the assistance to the end user when they are not available, but also providing the information and also insights to the carer to say, this is what's happened today, this is what's happening with this patient, these are the things that I can quickly inform you about to look into. So our solution, through an entire remote monitoring solution in itself, looks at ways of looking at the actual patient data, providing this digital voice-assisted companions to the user, which means that we can reduce the number of carer visits. And then the data that's being recorded and captured every single second of the day then can give you a clear output with regards to your dashboard or reports to what's happening to the patient or the cohort of patients. But most importantly, the AI behind our solution then puts on their insights into how to improve that patient's care. And that could be simply, George isn't drinking enough. George has stopped eating dinner, has stopped having breakfast. George is going to bed earlier than usual. Something is occurring. George is going to the bathroom 6 times every night. And these are simple things that you would think are commonplace, but they're not, because all solutions don't offer that level of information. And that level of information inevitably leads to carer assistance and the requirement to have less carer visits.
And I think as well, on a much lesser level, but something that is kind of interesting there, net zero, right? We obviously want to
Yeah.
get net zero. This is on a real tangent, but the one thing I always mention is if you can stop, if you can reduce, a person, one person having a carer from 4 times a day to once a day, and then you can multiply that by however many, that's a lot less trips that are happening, which obviously are not helping the atmosphere in the world, all of these trips with the cars and things. So just on a real tangent, I think just little things, they have other benefits outside of the initial kind of the obvious ones, right? The ones that they're intended for. There's lots of knock-on effects. And obviously one of the big issues, we've got our, we have our dashboard, we've got the app which tells, whoever's using it what they need to know across the whole range of things so they can have an informed decision, so on and so forth. But the NHS has always had a real challenge with their digital infrastructure.
Mm.
It's always struggled with, even though with new technologies coming out, there's new innovative, solutions becoming available. There's strides and trusts around the UK. Yeah, we always come back to the same thing that the systems are outdated. It's fragmented, like you said when you imagined it 30 years ago. It was kind of going to be one, central place where all the data's going. And it's just not like that because integration can be an issue, right? You can integrate with one of the kind of main ones, right? You can integrate with, whoever, Epic, for example, or whoever. And because you might be in 4 trusts that use Epic, right?
Mm.
And then you might want to expand to a neighboring trust and they may use something else. They may use Rio, and you think, oh my God, now we've got to integrate it with. And it creates a lot of extra work for people trying to make solutions and trying to kind of adopt them widespread in the UK quickly, so the NHS can start having positive outcomes with whatever the solution is, because it's very fragmented and it's very difficult to kind of, neighbouring trusts may use completely different systems, and it's very strange that that's the case.
Mm.
And I think that's something that would need to eventually happen, is just centralize the kind of infrastructure and say, right, we're using this.
Mm.
This is where it's going, and have kind of the one big pot. That's the dream, right?
Yeah.
Will it ever happen? How long's a piece of string? I don't know, because it's kind of a massive overhaul. But I won't kind of sit on that too long. I just wanted to quickly mention how you said around the carers having to go out, and then at the beginning you mentioned that obviously you kind of envisioned it be one central hub, and it'll be all nice in theory and nice and dandy. Everyone can just dip in, get what they need depending on the trust. But we see
Mm.
silos, we see all of these things, don't we? Which unfortunately were bound to happen when there's all of these different trusts kind of all doing their own thing under one big umbrella, but not really being like strictly held to do,
Yeah.
one thing. And obviously different trusts have different specialists and things. But as we look ahead to your next 25 years in healthcare, um, what do you think, what would you think are the most critical issues in terms of, is it policy, technology, workforce? What would you say right now, if you could, let's say your top 3 points, what would you say would be kind of what needs to be tackled? As you mentioned earlier on, if
Yeah.
they'd have asked you 25 years ago, you'd have said, we need to do this. I'm asking you now, what would you think would be the things that need to be tackled to create, one, a more sustainable, and two, a more effective kind of healthcare system that we can
Yeah.
maybe start to move forward, and it can start, what would you say? There's you go, balls in your court. What do you
Lovely.
reckon?
I think the first thing is, Paul, people need to understand what digital healthcare actually is. I think people still do not
Yeah.
know what digital healthcare actually is.
Hmm.
When back many years ago, we were talking about, oh, there needs to be one centralized patient repository where all information is stored so that you don't go from one hospital to the next and you're asked 25 times in each individual department, are you allergic to something?
Hmm.
Because you've already answered it once, why answer it another 10 times?
Hmm.
So, that's a very simplified way of looking at how data was looked at many years ago. Digital is all about not just the recording and capturing of data. That's massively important. That's really important. And believe it or not, some systems don't even do that very well. It's what you do with that data. That's what digital is all about. When you capture information about a patient, that data isn't supposed to be just there as an administrative tool. It's supposed to be there under AI, especially, as a way of assisting users to make their lives easier. That's the big thing that needs to happen here. And when you ask me the question about, how looking at the issues, what would I change? What would I tackle? Unfortunately, I hate to say this, and I've been through GP fund holder changes. I've been through NHS becoming trusts to their own businesses. I've been through other specific things like CCGs becoming ICSs and ICBs and so on and so on. I still think there are so many problems in the structure of the NHS. At least with CCGs, they had their own funding, they had their own responsibilities, and they knew what to spend their funding on. And so they were doing their due diligence, and they were looking at systems and solutions, and they were saying, yep, that's the one for us. And we have this amount of funding available, so therefore we'll spend this much on that system because we know it can give us the benefits we are asking for. Today, with CCGs no longer being available and now ICBs doing what they need to do and so on, I hate to say it, but there seems to be this silo effect where, social care is one thing, health is another. Who's got the money? Well, I don't have the money. And if there's anything to do with social care in this, I'm not paying for it because I'm health only. It just doesn't work that way. We have to work together. We have to work in a way where decisions can be made quickly and efficiently, yeah, absolutely, but in the right way. We can't keep on making mistakes where pilots are paid for and at the end of the pilot, we switch it off because it's no good. There needs to be a way where money is saved, the right solutions are put in place, the right benefits realization is there for you to see clearly, and then from there, the right systems are used quickly to help the end user. And that's what it's all about. Maybe it's because I'm not 18 any longer and I'm looking at the other end of the spectrum now, where I'm going to be thinking about, well, this is something that I'm going to be looking at in the next 20 years, 30 years, 40 years. I mean, centurions, people who are 100 years of age, that's increasing. And by 2030, there's going to be a massive influx of new 100-year-old patients. We need, whether we like it or not, to do something about that, because if we don't, it's going to be a massive problem where we're going to have, pandemics occurring where, people are going to start dying of flu again all over the place as it was in the old days. We need to really look at how we improve healthcare through the use of digital. And that is the biggest paradigm we have here. And hopefully we can get this to work because it's already been 10 to 15 years of digitalization already.
Yeah, and thank you for that, George. I think that is interesting, and yeah, you can be a centurion in a few years time, we can. But
many years.
It is, yeah. Don't worry, you're not quite there yet. But it is a worry, isn't it? Especially with you've got your parents, your grandparents, and there's a real worry just around in healthcare in general. Around if somebody goes to a hospital, it's like it's a risk for somebody to go into a hospital at the moment for an older person and they don't want to go into hospital because they know it's a risk. They think, oh, don't, and everybody wants to be at home and things like that. And I think, as you said, it's something that you quickly touched on just to kind of finish it and to add on what you've said. It's almost like with the kind of the reviewing and all of the testing of products, and as you said, some are done with competitors and that's bonkers, but like you said, there needs to be like a centralized body within the government or the NHS that tests all of these solutions. And then I know there's G clouds and all sorts of things, but then a catalogue almost is made, a digital catalogue, which says, right, here they all are, and it has the pain points. So obviously remote patient monitor, you click it and it'll do this. And it would be a big undertaking, but that would be kind of a centralized source of truth. And at the moment, we don't have a centralized source of truth, source of truth where somebody in Scotland can be like, right, we want to look at this, cool, and and then the same, Plymouth could say, right, okay, we want to look at the exact same, thing. Oh, them, okay, here's the contact, right? I'm going to reach out to George. I'm going to talk about, and it's very difficult for a lot of trusts nowadays to actually get the solutions in because there's lots of just jumping through hoops and red tape, and also like you said, finding the solution. We see it all the time. People are actively looking and wanting these solutions, wanting to make a difference in their trust, but they don't know where to begin. So you have
Yes.
all these events, you have all these kind of workshops and things. So I think that could be a really good way to at least start on the right foot. It's not the right way to put it, because we've been doing it for 15 years, but to kind of to begin again on the right foot is to put some of these actions into place. And it'll also, and then obviously with the digital infrastructure and that kind of whole range of things. But yeah, I think it's been a very insightful discussion for me. I'm sure lots of people listening will think the same. And obviously, to anybody listening, if you want to speak to George, you want to speak to us, as always, our LinkedIn is in the bio of the descriptions. George's will be there anyway as well. We'll also put George's email down there if you want to reach out to him, and kind of all of that good stuff. Obviously, if you have any questions or any topics you want on the next podcast, do let me know. If you have any questions for George, please let us know as well. He'll be happy to answer. And then I'm going to pass it back over to George just for any kind of closing remarks in case he wants to say anything to the audience.
Thank you, Paul. And it really is important that, you know, people do understand that we have to try and help our users. And I think if I can just let you know one last thing, I would say in the past, it was actually quite dangerous going into hospital whenever you actually, you know, whichever particular decade you look at, because everybody does the best they possibly can. But of course, there's infection in hospitals, and that can, you know, lead to you picking something up. You know, when I was on the wards in the old days, you know, we had winter pressures, we had ward closures over winter, where, you know, we had cross infection because our urology ward was next door to our ophthalmology ward, and we just got a cross infection that way. These things do happen. We don't mean them to happen. We try to stop them from happening, but they do. And who is the one who suffers? The patient who gets the infection in the first place. Even simpler than that, you know, you go into, I mean, my mum was in hospital for about 4 years that I kept going to see her over Christmas and so on because she was so poorly. But, you know, she was in a ward where I would go onto the actual hospital and I'd see specific ward closures everywhere because of norovirus, something so simple, but basically patients were getting it in the state they were in already. They were already poorly and ill, but they were picking up other infections because it's just impossible to stop that from happening. So what does that lead to? That leads to try to get the patients back home into their own loving environment where they can remain independent, and most importantly, they can remain safe in their own home. That's what we should try to strive to. That's whatever solution you create as a digital solution in itself, you should try as the actual output of that to get the user, the patient, back into their own home as quickly as possible to remain independent and safe, and most importantly, so they do not get readmitted, because keeping people out of hospital is what our whole aim should be. And that's what I'll leave you on, Paul.
Agreed, George. Definitely. Well, thank you for being on. It's been an absolute pleasure. Thanks for jumping on. And obviously, if as mentioned, all the links will be in the description. If anybody wants to reach out to George or ask any questions, please do. His LinkedIn will be there. His email will be there. Thank you so much, George, for being on today.
Thanks, Paul. Been an absolute
Cheers.
pleasure once again. Thank you.
Thank you so much for once again tuning into our monthly episode of the Health Tech Hub. We'll be back next month with a new guest, a new topic. If you want any topics, please let me know. We're happy to accommodate for specific topics that people want. If you'd like to be a guest on the podcast, please reach out to me personally on LinkedIn. My LinkedIn will be in the description below. And thank you again for tuning in, and we'll see you next month.